The House Oversight Subcommittee on Public Health and Food Security will come to order. Would the clerk please take the attendance?
Chair Beerline,
Here.
Representatives Paquette, Green, McDonald, Cerniglu. Here you have the quorum.
Representative Cerniglu moves to approve the minutes of the December 16th meeting. Here of no objection. They are approved. Good afternoon, everyone. Thank you for your patience. Today, we're going to continue this committee's discussion on hyperbaric oxygen therapy, safety, and regulatory practices in Michigan. I want to thank the committee members and testifiers who were able to make it in person today, and to those on Zoom who will be testifying. Your willingness to contribute to this important discussion is much appreciated. With that, we're going to get started first on Zoom with Dr. William Tettelbach, Chief Medical Officer of Restorix Health, and his colleague, former State Senator Judson Hill of Georgia. So, gentlemen, thank you for joining us today, and wanted to apologize again for not giving you time to speak at our last committee meeting.
I appreciate the opportunity to speak today. Thank you very much. Let me just share my presentation here, if you just bear with me for just a moment. All right. All right. So I want to thank you for the opportunity to speak here today to give further insight that was provided at the prior meeting. Related to hyperbaric oxygen therapy, sort of give an overview. We're going to touch on some of the same things, the safety standards, the regulatory considerations in this presentation. Just a little bit about my background. Again, my name is William Tettelbach. I'm the Chief Medical Officer for Restorix Health. We're one of the largest wound care hyperbaric solutions company. We mainly treat patients in the hospital or HOPD setting. We have over 300 sites across the U.S., a combination of monoplace chambers as well as multiplace chambers. I'm also the president of the American Professional Wound Care Association and the Wounded Hyperbaric Association. I am the former program director for Duke Hyperbaric Medicine Fellowship Program. We had a satellite program that worked in conjunction with the Durham, North Carolina site that was based in Salt Lake City, and that's collapsed back down to just at the hyperbaric program is just at Duke itself now. I also have appointments with Duke University. I continue to teach fellows within that program, as well as fellow or students or residents within the Western University Health Sciences program. And I also am an active member on CMS advisory panel in the hospital outpatient payment or reimbursement committee, and chair the data subcommittee. Now, when it comes to the hyperbaric, what is hyperbaric? We've kind of touched on that, but I think this is important because there are other issues to think about when it comes to what is being used to treat with hyperbaric. But typically, the working definition is considered breathing 100% oxygen continuously or intermittently inside of a pressurized chamber that is a pressurized chamber for human occupancy. And for clinical purposes, this is at greater than or equal to 1.4 absolute atmosphere. So think of the column of air that sort of pushes down on us in the atmosphere. If we're at sea level, that's one atmosphere. If you go down lower than sea level, that column becomes long, it goes longer and pushes down more, and that's where you get increased pressure. Likewise, if you go up, and say in a plane, if it's not pressurized, the atmosphere's reduces. So why does this matter? Well, the evidence-based indications that are published, the UHMS provides these, CMS determines what they're going to follow. The definition and the indications are also supported with the American College of Hyperbaric Medicine, and these are periodically updated. And they're based on studies the majority of these studies, or all of these studies actually, that are published and go through peer-reviewed channels are typically done at greater than or equal to 1.4, 2 point, there's a wide variety, but these are typically above that. So that's where, if you're following evidence-based medicine, where we need to land. And not all, we do have low pressure chambers, or sometimes they're called bag. Not all of them are bag. They have other dimensions to them, but not all of these meet the clinical definition of HBO therapy. And common, the hyperbaric, again, is commonly used as an adjunctive to standard of care. So it's not necessarily the primary treatment, other than if you were treating carbon monoxide poisoning, or if you were doing air gas embolism, that would be the primary treatment. But it's, we see a lot and treat a lot of these. I think in both, this is done in private offices, definitely done in hospital-based clinics, where we're seeing complicated diabetic foot ulcers with deep infections, osteomyelitis, and radiation injury that definitely benefit from this type of therapy. So common delivery locations, as I was mentioning, we think of inpatient hospital. This could be, like say a burn center with embedded hyperbaric oxygen therapy tanks. There's the HOPD, or hospital outpatient department wound centers that have hyperbaric, that offer hyperbaric oxygen. Some of these are hyperbaric oxygen therapy clinics that are standalone. They don't have, or they're not associated with a wound clinic. And then there's independent freestanding, that would be non-facility clinics that are outside of the facility setting. So in the hospital setting, these are primarily for acute or emergent indications. They have integrated emergency responses. They have hospital policies that govern staffing, drills, or maintenance that align with the specialty standards. And there's oversight via hospital licensing, accreditation, also state oversight and licensing. The hospital outpatient departments falls under this umbrella. They commonly treat CMS covered indications. There are times when they're outside of these indications that are appropriate. There are studies that support say like traumatic brain injuries, mild traumatic brain injuries, that are not yet indications. There are other ischemic type issues that can happen with bone that are covered by, say, commercial, but not Medicare. That would be off-label for Medicare, but it is actually, there's data to support this. Another thing I wanted to point out is that in the hospital-based setting, if you put Restorix Health and one of the other large management, wound and hyperbaric management companies, and look at their record of treatment over 20 years, we have probably combined about 4 million hyperbaric sessions. And in this, there's never been an unexpected reportable adverse event such as death. And a lot of this education that we're doing now, some of the regulatory statutes that we're looking to possibly bring into being have resulted from some of these traumatic happenings, such as the young patient that died in Michigan. But these were freestanding clinics, but in the hospital-based setting, there is very strict and rigorous oversight and accreditation that happens through the Joint Commission, where this has never really happened. And in fact, the hospital themselves, be it independently run or oversight with these management companies that have very rigid protocols and safety measures that they want to follow, because no one in these type of settings want any patient harm to occur. That we're here for do no harm. It's really part of our oath. Hospital policy, again, same policies that govern the inpatient govern the outpatient. And again, oversight via hospital licensure and accreditation structures are already in place. The independent freestanding clinics, however, their services can vary from medical HBO to wellness offerings, other off-label where there may not be a lot of data or over promises. The oversight, licensure, and safety and training varies widely. And in Michigan, reporting has highlighted gaps in state-specific licensing and inspection. So there's definitely, I think, the agreement that there needs to be increased oversight in these areas where there's independent or freestanding clinics, but we don't want to get to a point where we're over-regulating to the point where access can be inhibited for patients. And there's a real possibility of that, especially in an arena that has a proven safety record, where there's always room for improvement, but the safety record sort of speaks for itself that really there has not been any major reportable unexpected adverse events. Now, the safety, the standards. So the core safety framework commonly referenced, in the medical hyperbaric therapy programs. Again, there's the National Fire Protection Agency 99 Chapter 14 that specifically puts recommendation and guidances for hyperbaric facilities. These are codes that should be enforced, and there's within these designated hyperbaric safety coordinator responsible for the equipment and operational safety within Restorix, hospital-based clinics. These are the ones that I've worked in. I've worked in Intermountain Healthcare, HCA, and now Restorix. This is typically, because of the oversight and regulations, we have a safety coordinator. Now, the safety coordinator is responsible for setting up the protocols, inspection of equipment, but they're not necessarily there because everything is set in place there for every day-to-day business, but they're always should be readily available. Fire prevention and precautions are critical. Again, this is an oxygen-rich environment with heightened fire acceleration risk, which occurred in Michigan and has occurred in other freestanding clinics in the U.S. And again, following the device instructions for use, maintenance, staffing, training is essential to all of these. Now, equipment, again, pressure vessel standards for that have human occupancy. They're designed, typically FDA approved. That's what the oversight is targeted for. You want to keep good documentation of preventative maintenance. So if you do have, say, state inspectors come in at any of these sites, that they can look at those logs. Those logs are actually looked at by the Joint Commission when they come in and look at these hospital-based clinics. But that Joint Commission obviously does not look at independent freestanding sites. So their oversight and accreditation, I think, is something that we would agree on. The clinical governance and we were talking about the accreditation, given the history. Best practices is to designate hyperbaric medical director. All of these are facilities, and I would say 100% of the hospital-based clinics do have medical directors as well as safety coordinators. And again, they go through a facility accrediting evaluation for adequacy of their equipment, the safety processes through Joint Commission. There are actually some electively UHMS and the American College of Hyperbaric Medicine have accrediting processes that can be done for these, but more so needed for the, I think, independent freestanding clinics, so that they are at par with the hospital-based clinics. And again, accreditation can complement, but it really can't replace state licensing and inspection, which would be, I think, an improvement if this was added on to, say, what is already happening in both these arenas. And again, patient-centered priority, we want balance of safety and access to establishing clear risk-based standards while avoiding unnecessary barriers for our patients. And when you do, there's definitely a middle ground where we want to be, where we're ensuring safety, but access is key. I think lastly here, the Michigan policy, it strengthens safety while we're preserving access. Again, the policy levers and minimum safety baselines, I think for all, again, facility registration. This is key because some of these mobile, low pressure chambers can be anywhere. They can practice fee for service, but they're hard to regulate and definitely need more oversight. But again, facility registration and licensing for chambers delivering greater than 4.1 or equal to adopt acquired compliance with the National Fire Protection Agency 99 Chapter 14 require pressure vessels for human occupancy, complement and FDA cleared equipment. Make sure you're using FDA cleared equipment and documented preventive maintenance, accreditation of HOPD hyperbaric clinics or therapy clinics are under the umbrella of the accrediting bodies such as the Joint Commission, designate medical director and safety coordinator. Again, how those are utilized. Again, the providing, according to CMS and their guidance is the treating attending physician of the day needs to be readily available, but does not necessarily have to be at the chamber throughout the treatment. And this is also would be the same for a safety coordinator, because you have to consider if you typically hire one safety coordinator. If that individual is on vacation, then everything comes to a halt. There's no patient access, but again, they can still be readily available on phone. If you're trying eventually to have a 24/7, I ran 24/7 critical care. If you had to have the safety coordinator available for those treatments, you could be treating all day long. That individual would never go home. It's physically impossible. You would have to make everyone the safety coordinator, which again is not a standard within this specialty. That's just highlighting that, because there are 24/7 in other areas of the United States where they have one safety coordinator, and it is the standard that they are not there for every treatment, but they're setting the standards and the safety standards that need to be followed for every treatment. And again, in services, emergency procedure drills, clearing patients with consent. Now, oversight for freestanding, again, routine inspections, surveys, and coordination with the safety authorities. We typically will do that in the hospital base, where the fire chief or fire marshal will come in for fire suppression inspections and things like that. That is with multi-place, but again, you can still run drills and have those safety authorities understand and have logs on the freestanding side, which may not be happening routinely. Reportable adverse events, root cause reviews, an accreditation pathway. Both the American College of Hyperbaric Medicine and the Undersea and Hyperbaric Medical Society both have these, or if there's another equivalent that can be used. There's clear boundaries between wellness, the low pressure sessions with say these mobile bag type chambers and medical hyperbaric therapy claims, and then patient access safeguards. So transparent pricing, referral patterns, and payer alignment. So that's kind of my overview of what, on top of what was already given in the past. I hope you find this helpful. I'm available at any time for questions. I don't know, Senator Hill, if you have anything to add to what we just presented, but again, thank you for the time during this session.
Chairman, would you like me to make a few comments before you have Q&A, or what's the...
Yes, please. Go ahead, Senator.
Well, thank you again, Chairman, for the opportunity to share with you, and also members of the committee. I also applaud your staff along the way. They've been a great resource in helping line this up. I'm Judson Hill. I was a Georgia senator for 14 years, and all that time I served on the Georgia Senate Health Committee, chaired a number of committees along the way, and was in leadership. Probably maybe one thing relevant for here is I was on the board of 2 national legislative associations, and I chaired one of those health committees on one of those associations for about 5 years. And so I spent over 20 years actually in health policy, and that's how I came to, first meet Dr. Tettelbach. when I was talking to y'all earlier about this hearing today, it was really, I think your request was to help focus on what the state role is and also what's going on perhaps in other states. I think Dr. Tettleback did a real clear presentation on what the state role is and what the opportunities are for the state in this field, especially looking at that slide 4, which on my screen still shows up of the state policy considerations. Simply, it's patient safety and focus on ensuring patient access to medically evidence-based care and doing that in a safe facility with safe equipment. I would just refer you back to his slide on what safe access looks like, what safe equipment looks like. For example, the federal and the federal national fire standards, the NFPA 99, and also the equipment standards PVHO 1, and focus on it. Clinical accreditations facilities, as he clearly delineated, you've got the hospital, the HOPD, and the independent freestandings. And for decades, it's the hospitals and the HOPDs that have had to adhere to all these high accreditation and other safety and accreditation standards and oversight and regulations that are in place at the federal level and the state level. Excuse me for coughing here. And that's been in place. And frankly, I don't recommend reinventing the wheel here. I would recommend that you look and continue to look more closely at the freestanding and independents that are not or have not all been required to be accredited or regulated or have the same registration and oversights at the state level that the hospital and HOPDs currently are required to have in place there. I wouldn't recommend a place in a burdensome regulatory structure that actually harms patient access and impacts negatively hospitals and the HOPDs, but put a program in place, perhaps through regulations for a light touch, perhaps in the statute, which would focus on this on patient safety with equipment that's accredited and compliant with the federal standards and the fire standards and CMS FDA standards, and also on facilities. And once again, reinforcing what Dr. Tettleback said, I think it's complementing what's already in place and doing that at the state level in Michigan. I think would be wise to seriously consider that. Pausing to look at the states. I mean, frankly, Michigan's on the cutting edge of some of these oversight regulatory standards for facilities and equipment at the state level. There are a handful of states that are looking at and have introduced legislation related to this field. There's 4 that have proposed a pilot program for giving veterans access to these procedures for traumatic brain injury and PTSD. Those bills haven't passed in these 4 states, the closest one to y'all being Indiana. And there's 3 other states to make up a total of 7 states, but 3 other states have just urged Congress to take action. And so you got 7 states that are doing something. The 3 of those 7 are urging Congress. They're not taking statutory action. And then in Congress, there's 2, perhaps if you count 3 pending bills that have been pending for a better part of a year now, one in the House, one in the Senate, that focus on veterans and giving veterans access to these treatments for traumatic brain injury and PTSD. So that's the overview at the state level. From the standpoint of y'all are on the cutting edge, I believe, at the clinical facility oversight level and possibly bringing in freestanding and independence into that existing set of standards that's already in place for hospitals and HOPD facilities. So focus on access to care. At the same time, obviously always focus on good patient safety, and doing it in safe facilities and with provenly safe equipment that's compliant with FDA standards and all other standards that are currently in place at the national level. Hope that is helpful. And once again, as Dr. Tettelbach said, here to be helpful in this arena as y'all weigh in here on the regulatory side, which I've had extensive experience in, as well as the statutory side. And I'm open for questions and I know probably moreover, you probably may have some for Dr. Tettelbach. Sorry for my red face here. I ended up at the dermatologist, having spent time growing up in South Florida, and they put me under the mic. Anyway, had some treatments and caused me to look like I'm a red apple, but finally, I saw my face show up here and was like, no,
You look good.
No problem, Senator.
so good, but
I'll go with
thank
the
you.
first question. Yeah, thank you both for your time today and your patience. I guess a lot of times when we approach new restrictions, new registrations, accreditation for things, it can kind of be seen as sometimes gatekeeping, that the folks who have already accomplished the kind of epitome don't want other folks to be able to get into that market. So my question for both of you would be, do you see a place for the folks who are outside of the hospital setting? There is room for kind of, that wellness setting and the more severe treatment that has the higher regulations and the higher atmosphere, the higher oxygen levels. I just want to make sure, as we are approaching what the right kind of regulation is, that we're not overly restrictive. And so I would just kind of like to hear your thoughts on that.
So I'll answer first on that. It's Dr. Tuttlebach, but so I agree. There is a whole budding industry of say wellness and utilizing hyperbaric. These are not necessarily based on. There may be some evidence for these, but they're not indications that are covered for per CMS. But if these are, individuals may be searching these out to utilize this service to see if it's something that could help. They're, treating off-label. I'm also an infectious disease doc. I have to say that, antibiotics and other things that we use they all have specific indications. We use off-label all the time. If we did not, there would be a lot of probably people who would never have survived certain infections or sepsis or whatnot. So this is where, the sort of the why we are, treating physicians and have to, we have to use our broad knowledge to bring that forward. But in the end, I would want the equipment that is being used to be just as safe as the equipment used in indications. In other words, the antibiotic I use has to be under rigorous, good manufacturing practices. It's not being made, in some garage somewhere or non-FDA approved, through the normal processes, but it is maybe used beyond, say, its indication of just treating pneumonia. It could be used to treat osteomyelitis or bone infection or intra-abdominal infection. It's just there's a translation there. But so I agree that there would need to, I still believe that there needs to be a level of safety standards for any of this equipment that is going to be used to treat patients. Now, saying that it has to only be for that indication, we follow that in the hospital setting because there are, when you are treating Medicare patients, there are rules that if what you're charging your patients for say non-Medicare treatments, they have to be equivalent to what you're charging Medicare. So that is a guidance that's already where we are put into that position just because we're in a institutional structure, and all these hospital-based clinics have to follow that institutional structure or create pathways for charity work and for fee for service. There could be discounts for cash pay, but in the independent settings, they just may take a fee for whatever they're doing, and there'll be no declaration to Medicare whatsoever, or they just take the physician oversight fee and nothing else. So, but in the end, you want that equipment to be safe. In the end, you want those individuals following the safety protocols and not ignoring them. And that's where licensing and registration and state inspections can be helpful, as well as an independent having an accredited facility. So, Senator Hill, if you have anything to add to that.
No, thank you, Doctor. There, as chairman of Health Committee for a long time and chairing lots and lots of hours of health policy, I'm sure you have and others have, obviously there in the legislature. The methodology that what I would recommend is there's a set methodology already that's in place for how to make these decisions, and it would be balancing. Really, it's a balancing approach. I would follow the methodology that CMS and FDA and they're already in place for accepting and approving certain types of facilities as well as equipment, because there's studies out there that are peer reviewed. There's advanced treatments, early treatments that we all know that are cutting edge, that just because it's not in place today doesn't mean that science isn't going to show that some new treatment is in place tomorrow. We hope and pray that that is the case every day for all these types of healthcare conditions. I'd use a balanced approach. I'd look at peer reviewed. I look at the FDA, other outside bodies, CMS, the national standards, how they go about making these determinations, and also ask the question, what happens if something goes wrong with certain types of treatments or facilities or equipment? And look at that as well, as because some types of treatments we have, like the one I had on my face the other day, it's something, it's you're red for a few days. You get in some of these chambers and if something goes wrong, the results can be much worse. So I'd use a balanced approach and follow the methodology that's in place, existing methodology in place.
Thank you. We're going to take some questions from the rest of the committee. Representative McDonald.
Hello, everyone. Thank you for your testimony. I didn't think I'd be mentioning my bill package here today, but I guess I will. What we are trying to do with that is to make facilities outside of, or standalone facilities, as we usually talk about, standalone HBOT facilities just as safe as the ones in hospitals. So that's what we're working on. And the big difference, like I don't have a problem with off-label use. We're not trying to stop anything that people do. We do want people to be aware if they're getting treatment that is covered by FDA guidelines or not. I think that's fair, that consumers should know what they're getting. Actually, the problem we have with the regulatory structure is not interested in whether it's inside of a hospital or outside of a hospital. We just want everything to be safe. But there is some information that you were talking about, Dr. Tettelbach, about hard-sided versus soft-sided HBOT units. And that's, I think, one of the biggest questions we all have. Could you describe very simply, I think what, I just found out recently that a hard-sided HBOT unit delivers 100% oxygen and over 1.4 ATAs, which is about the pressure. Could you compare that to what soft-sided units provide and what the medical difference is between those two things?
Well, in regard to that, there are different levels of those soft-sided. mild, and those that can go higher to, can go at least to 1.4. The majority do not. And a lot of these were, I think, the invention of these was used for, mountain sickness, trying to bring folks down, who have flash pulmonary edema and complications, where they needed to be brought down, a certain degree, put under pressure, so that instead of being able to bring them down the mountain, they could just put them in the bag and treat these folks. But this is, and also have used in diving, where there may be needed transport, and these bags could be used as well. Not all the bags, are set up for 100% oxygen continuously. It may be air, that is used in these. The oversight, I think some of the problems with this is if they're done in not in regulated facilities, but say done in home setting or done in a back room of some other unknown location, you may not have the oversight where the hard chambers or the multi-place chambers have a technician that is there during the whole run, that is part of the protocol, where it's done, and if the patient has any complications, they're addressed immediately. Where if the patient needs to come out or something needs to be changed, an air brake, where there's been instances where folks have been left alone and these soft chambers have decompressed rapidly, which could cause ear or other lung collapse or things like more severe. There's been reports where a child has been put in where they were treating. I'm not quite sure if it was autism or something like that, where they were left alone and the oxygen or air source cut off, and that eventually was a situation where that individual suffocated. There's problems with the components that come in with some of these soft bags, that they're not all up to par, where they're being shipped in. They're not the quality of these. It's not to say that there aren't quality chambers that can go up to this, but the majority of these may not meet these regulations, that the same type of strict regulations that have to be met with these hard chambers. It's a difficult scenario, I have to admit, when you're bringing these into play and how to regulate them.
Doctor,
I wish I had all the answers for it.
Yeah, are there different levels of the soft-sided? Like, are there FDA-approved soft-sided ones versus ones that are maybe just manufactured for home use that are not FDA-approved?
Yeah, well, for sure there are those that are not FDA approved, and I have not spent my career, in the working with the soft shell, but I do believe there are those that are up to par and meet those specifications, and those are the ones I would approve of. If I was trying to regulate, I would definitely want them either FDA approved or meeting the standards of the industry standards.
Representative Green?
Thank you so much. I'm trying to formulate my questions because you guys keep asking good stuff, and then it triggers more. So we have a room full of veterans in here, and so I know that that they have used HBOT for the treatment of PTSD and other ailments in the VA. Do you know if they've only strictly used the hard side for those research, or do you know if they've used the soft-sided as well?
So fortunately, I can speak to that because I was when I was at Intermountain Healthcare, I worked with Lynn Lever, who had a DoD project study looking at that. Those were all done in multi-place chambers or monoplace. They were hard side chambers. It was an interesting study because there was benefits found actually with say lower level at 1.4 versus above 2. So it opened the door for mild traumatic brain injury, and then at least in the U.S. And there was actually a new study, I think it's Hybabi study, that just got published, and it also looked at that and showed the benefit. They ran that study at 1.4 on oxygen, and there was clear benefit to the neurological status and memory of those with traumatic brain injury. There was actually retrospectively, they wish they had done higher levels along with the 1.4, but that was the cutoff. So again, that fits the criteria, the defining criteria of hyperbaric at 1.4 or greater. And this is, I am a big, having seen this and been part of these studies, a big proponent of bringing these to veterans who have experienced a traumatic brain injury, but there needs to be the type of oversight that you're actually getting baseline neurological evaluations, I think, before you start the study, start the treatment, and then look at the response rate. It would be no different than if I was treating sudden, hearing loss, that I would get a baseline hearing test and then start treating my patient, or I get it early on in the course to see if the patient actually is benefiting from this, and continue as long as there is shown benefit, meaning that they can concentrate better, their coordination is better. We've seen this, and we treated a Navy pilot who got, for lack of a better word, bad oxygen or air, and had an hypoxic event, which was in essence a brain injury. And after completing the sessions, seeing the neurological testing, he was able to go back and fly, which at one point they said you'd never fly again. So this was active military, but the same holds true for veterans. So I'm not aware of published studies done with the bags. But again, if you had a chamber that can go to 1.4 or greater, be it hard or soft, that is meeting the criteria and there's ensured safety, meeting the criteria needed to treat that condition.
So as a follow-up, access is a really big issue, especially in the rural areas where I live, my district, we don't have a hospital. And so there's no hospital-type facility to hold these units in. There's community-based outpatient clinics with the VA and stuff, but even still, that doesn't even reach all of like the thumb, for example. So how would you suggest that we overcome not having the hospital setting but still having access, especially if some of the units at a lower level have shown to be even a little bit effective?
I'm unaware if it's been shown effective, in published studies for this. It may be anecdotal, but we don't necessarily drive evidence-based medicine with anecdotal evidence. Again, if there are chambers that reach the criteria and safety standards, can at least do 1.4. But again, you don't necessarily want these in home without the same oversight and regulation, especially if you're doing 100% oxygen. So they're going to have to meet the same criteria. We can't, I agree, we need the outreach, we need the access, but we can't sacrifice safety for the outreach. So
with that then, if the unit itself meets a certain standards and requirement, can they be placed anywhere then?
It has to be when it comes to chambers, like we want to use hard chambers, there's definitely definitions of the size of the space, how close it can be to walls, where the oxygen's coming from. This is a whole new view with mobile, so somehow if you apply those same safety regulations, if not, then why do we have it for the hard chambers? I mean, I agree. If we actually increased access, if you actually increased the ability, adequate funding or grants to treat, say, TBI or PTSD, I can guarantee you there would be an increase in centers bringing in, or clinics coming, coming up that would have better outreach in, more rural or community clinics. We have all sorts of critical access clinics throughout the United States that are just wound care only. But yet, if there was but if we were able to expand the indication on this, there would definitely be growth in incentive for these hospitals to expand their services.
And if I may
the
weigh in,
the soft bag could go along with that. I mean, but first establishing the system and then allowing the growth to meet the requirements of that system. But first you have to establish that, and then have, if you were saying that if you establish the treatment, not worrying about soft or hard, saying that we will do a grant, that we will treat, say closed, traumatic brain injury, but it has to follow protocol in the sense that it has to be 1.4 or greater, has to be oxygen, and they have, they have to meet certain requirements, the chambers themselves, and then we would want evidence of improvement to continue these, such as baseline testing. That is what you would, I think, set up to allow the whole industry to morph or grow under the guidance, because people will reach those standards if you set the standards needed for those grants.
and just in follow up on that too, and I can't see who's on, but I think it might be Representative McDonald, and appreciate greatly the work you and your staff have been doing on that, as well as also Representative Schmaltz's work, and even Senator Chang over in the Senate side. It's a balance, as Dr. Tettelbeck discussed. The pilot program may be best. We have critical needs, healthcare needs that are different in rural healthcare, and veterans, in my view, was a JAG officer related to our Army National Guard, they deserve the same level of care, at least the same level of care and access and quality care that any other American does across our nation. That's for sure. You wouldn't want to compromise the level of the care because a facility was compromised in the standards, I think is where also Dr. Tettelback was touching on. But in the pilot program, you may be able to find a public community health clinic or some sort of setting that could be regulated, that would provide a safe location. There may be freestanding clinics that comply with these same standards that we've been discussing today, that would be a safe environment. So it would provide access as well, an affordable access, as well as a safe environment, and tested through a pilot program like maybe being proposed, and also this looked at in other states as well as a federal level. And in the meantime, hope better funding comes for the veterans through the VA, if it's not already appropriately there, for the different settings that are qualified for safety that meet and satisfy all the safety as well as the medical-based standards.
Yeah. So let me add one more thing, because I think to me, this is very exciting. And if you set up a model that can be adopted more rapidly, not just based on chamber, but what the grant would cover, this would give a lot of, I think, motivation and backing to take this to a federal indication with CMS. This is only the beginning, because there's data supporting this, and in other countries they treat this. Israel, Russia, this is under their indications, and these veterans and those with traumatic brain injuries are benefiting from this. And this is where the NIDIS is on a state level. It just needs to be done right, so it can keep expanding and affect all veterans throughout the United States, not just in Michigan.
Okay, there's one more question, gentlemen. Representative McDonald.
Thank you. I'll go as fast as I can. I just want to reiterate that in my package, because this is said wrong so many times, this is not only for in hospitals, so the units do not have to be in hospitals. They're standalones. There are standalone hard side facilities all over the place. As a matter of fact, it's hard to find them. That's one of the reasons we want to register them, so to make sure that they're safe. I also have 4 studies in front of me that say that hard-sided work better in the research that has been done on PTSD and PSC, and I think that our veterans do deserve to have safe facilities to get their treatment in. Thank you.
Well, I want to thank both of you gentlemen for being here. Sorry again that we weren't able to get you in the last committee, and I'm sure that we'll be probably hearing more about this maybe in a health policy committee versus the oversight side. So thank you again, both of you.
Thank you. I applaud what you're doing. You're on the cutting edge across the country.
You are.
Once you establish, these standards, really other states are going to follow suit. It's critically important, the work that you're doing on behalf of the veterans and the people of the state of Michigan. And it's not just, doesn't go without saying, we applaud that because we're not seeing it anywhere else really in the country like what you're up to. Thank you.
Yes, thank you.
Thank you. I just want to announce to everybody before we start with our next presenter that at 1:30, due to session starting, we are going to take a short recess. It will be 15 minutes, and then we're going to continue because session will be closed at 1:45. So I'm just making sure everybody understands. So with that, we're going to have our next presenter on Zoom, Dr. Jason Saunders.
Thank you. Can you guys hear me okay?
Yes,
Terrific.
yes.
Screen, just want to make sure you guys can see that. Can you see the slides? Hello?
Yes.
Can you guys see my slides?
Yes, we can. Or we
Okay, great.
could. Yep. We can see your screen.
There we go.
There.
All right. Well, thanks also to the committee and to the previous presenters. In many ways, I guess I'm here to discuss hyperbarics, but I guess comparative to the last presentation, present, I'd say, the freestanding side of some of that conversation. So before I start, because I do have a lot to talk about and I don't have a lot of time, but let me just first say that we agree on more than we don't agree on. So we agree that we need not necessarily to reinvent the wheel in terms of regulations. Actually, there's quite a lot of regulations that exist that work well. And to overregulate this in a response, not to minimize the accident in any way, shape, or form, but to maximize regulations and then interfere with access, whether it's for veterans or for other people looking for this therapy, I think would be a mistake. And I don't think we need that as much as we need to work together, find common ground on what rules and regulations already exist and how to just more universally apply them in each of these different environments. And quite honestly, Dr. Tettelbach, that sounds like what you were saying earlier. And so, I guess quick background. So I've been in practice for 22 years. I've been using hyperbarics. I run 2 different hyperbaric clinics, one in New Jersey, one in Pennsylvania. We've treated thousands of patients over, 2 decades. Over the last 7 years or so, I've been teaching hyperbaric. So I certify practitioners in hyperbaric medicine. I also certify people on the safety side. We say safety director. Dr. Tettelbach was saying safety coordinator. For all intents and purposes, I would say that that's the same role. And I guess I've also written a couple books on the topic. So, 2 books, one being a textbook that actually is being used throughout a lot of the freestanding and potentially off-label hyperbaric world. and it mimics a lot of the coursework that we teach in the courses that we offer in certification of hyperbaric medicine. So we agree on that. We agree on the training. We agree on the roles. We teach everyone they need to have a safety director, a safety coordinator. We teach everybody that they need a health practitioner, a licensed healthcare practitioner oversight, while they're operating. Now, those people, again, agree they're not there at every moment during a session, but they're always available. And there's a role that they play as far as like top-down organizing protocols, organizing policies and procedures, organizing maintenance and safety inside the clinic. And I think, not that these aren't important, but one of the most important things that I think we agree on also is the fact that we need to be making sure that everybody's operating approved equipment. Unfortunately, because of the growth of this industry, manufacturers of hyperbaric are coming in left and right, and a lot of these devices are not approved devices. They don't meet, on the hard chamber side, ASME and PVH01. They're not even pretending like they need to. They think that they're actually outside the rules and regulations. On the soft-sided chamber side, not meeting any FDA regulations whatsoever. And so I think that's one of the most important places where we could work together to figure out how to ensure that people that are choosing to run hyperbaric chambers are also choosing the right equipment and then getting trained appropriately on all the policies and procedures that ought to govern this. So, quite honestly, there's a lot there that I think that we agree on. I also just wanted to make one little correction. It was earlier said about soft-sided chambers. They're never pressurized with 100% oxygen. They should never be pressurized. That's well established in the soft chamber side of the industry. Those chambers are always pressurized with air, and on some occasion, some type of oxygen may be brought into the chamber through usually a mask of some type, obviously maintaining the 23.5% or less oxygen inside that ambient environment, but essentially never being pressurized with 100% oxygen. And, although Dr. Tettelbach was talking about the hospital environment, primarily, the hyperbaric industry as a whole has had, certainly has had accidents, and those accidents deserve the attention. Those accidents deserve an understanding of what happened. We teach all the different accidents when I teach my certification courses, because it's a learning opportunity so that we can understand what happened, what went wrong, and how to avoid these things in the future. And the one thing I can say confidently across all of hyperbaric accidents of the past is that they were all a deviation from the existing standard of care. And as I started this conversation saying, there's already so many rules and regulations inside the hyperbaric industry. What we need is to understand how to work together to make sure that we are enforcing and educating people what the rules and regulations are. But every single accident has not been because of the equipment itself. It's always been a deviation from the standard of care, something operator error or contraband in the chamber, something in the chamber that should never have been there in the first place. And that's not unique to, let's say, the off-label world versus the on-label world. It's not unique to hard chambers versus soft chambers. It's not unique to multi-place chambers versus monoplace chambers. This conversation is universal and should be universally applied inside of all hyperbarics. And if we got to a place where we learn from those mistakes and not vilify the industry, but understand how to keep and make sure people are accountable for their actions, their policies, their procedures. You're choosing to offer hyperbarics in your clinic. Are you now also applying that appropriately, both from a protocol standpoint, a billing standpoint, but also from a safety standpoint? And I think these are some of the most important concepts that can come out of a meeting like this. So let me just, I guess, touch on a few other things that I wanted to make sure that we talked about. Dr. Tettelbach offered a definition of hyperbaric being breathing 100% oxygen, either intermittently or continuously at a pressure of 1.4 or greater, atmospheres absolute. And I would say I'd like to shift that and say that hyperbaric literally means hyper increased baric pressure. And so oxygen absorption inside of our body goes by passive diffusion, meaning there's no active way to draw oxygen into our body. It has to happen by some other dynamic, and that's through diffusion, passive diffusion. And so concentration of oxygen has to be greater outside of our body than it is inside our body, so that as we breathe air, even right now from our environment, we're drawing oxygen into our circulation. Any pressure greater than whatever pressure you are adapted to would start to increase oxygen absorption in your body. It's physiologically impossible to have it any other way. As we drive increased pressure, and if we choose to add additional percentages of oxygen, we're creating a larger gradient or a larger driving force of that oxygen into circulation. But the moment you even get to 1.1 or 1.2 ATA, something physiologically is happening. I like to, when I teach these classes, I like to say that, you know, the lowest known therapeutic level right now is about 1.3, although I would say that there's probably a place for even lower pressures than that. And it goes all the way up clinically to about 3 atmospheres. Some people are using air only, even at higher pressures. Some people are adding air only, even at lower pressures. And some people are adding oxygen at lower or mild pressures all the way through the higher pressures. Now, in the hospital setting, I'd say from what Dr. Tettelbach said earlier, certainly there's an expectation that those pressures are over 1.4, usually closer to 2 atmospheres or more, and almost always using 100% oxygen, either ambient or, you know, through a mask or a hood. Though what I believe is that our job isn't to say that there's a singular right pressure or a singular wrong pressure, or there's only one protocol. I believe based on the health concerns, I believe based on the health goals of the patient or the diver, and whatever we're trying to accomplish through using hyperbaric, and their tolerance, right? Not every patient's going to tolerate higher pressure as well. So our job is to understand the requirements that this patient is in need of, understand the pathways that our modality, this hyperbaric therapy, is driving, and try to match the proper pressure, the proper protocol to whatever the goal or health concern happens to be. And I'm also a student of the minimum effective dose. So I'm not looking for the most amount that a patient could ever tolerate and call that the best protocol. I'm looking for the lowest amount that a patient can receive, but still have a positive outcome, because that way I'm actually decreasing their risk. I'm decreasing any adverse reactions that they could have, but I'm still maximizing the benefits. And there's a delicate balance there. And that's why we call it practicing, because it is an art, and it takes time, and it takes confidence, and it takes experience to really hone in on skills like this. These are the types of things that people who are taking the courses, my course or other courses, really need to understand in order to do this safely. Now, I think Dr. Tettelbach also mentioned the on-label, off-label conversation, which I appreciated his position, although I know that other people don't share that sentiment, and there's an issue between this on-label, off-label debate. And quite honestly, as Dr. Tettelbach said earlier, we use medicine off-label all the time, very frequently. But the key is the tool had to be approved. In other words, if this medication was deemed unsafe, you can't use it on-label or off-label. It wouldn't even gain on-label status because it's dangerous. So the tool has to first be deemed safe. It has to then have research to support the use, and then we build indications over time. However, as long as we understand that it was safe and we use our clinical judgment, we can use that off-label if it's appropriate. And that's, again, a way that we need to learn and gain experience how to apply that appropriately in hyperbarics. So on-label, we could be treating conditions. Off-label, we're not treating conditions. We're just supporting their physiology, because we haven't gained, let's say, the level of research required to earn that indication yet. But as I said earlier, it has to be deemed safe for human use. That's number one. And when it comes to these chambers, there are quite a few chambers on the market right now that have never been safety tested. They have not gone through the safety channels. And so therefore, my argument for when someone says, well, I'm using this chamber, well, I use it off-label, why do I need an approved chamber? Because the device has to be proven to be safe before you can apply it any which way you want. And that's really the crux of that conversation. If there is the research to support it, we get these FDA-approved conditions. In hyperbarics, they're predominantly life and limb. In other words, severe infection, severe blood loss, losing your hearing, losing your eyesight, about to have an amputation or, severe burns, those are life and limb type of scenarios. And in a hospital setting, all 15 approved indications are that severe. And for those types of conditions, it makes perfect sense to also apply 100% oxygen at pressures that are moderate to high. 2 atmospheres or greater is commonplace in that scenario. But we're having to apply a really more aggressive therapy for a very severe condition. And that makes perfect sense. And really, the FDA approval process has more to do with, are you treating the disease or supporting somebody? And can you market the fact and say to the world, I'm treating this condition with this tool or this therapy? Compare that to the off-label use. There's dozens of off-label applications of hyperbaric, and they should not be applied willy-nilly. They should not be applied, I just think this might work, or because Jason said so. Like, there has to be a very specific thought process that we would all use, clinical judgment, understanding what's the pathophysiology of the patient, what is the mechanism of action of my tool, and does it make sense to apply these mechanisms for this pathology, and should I, A, know that I'm keeping somebody safe, and B, understand that it's likely to have some type of health impact in the direction that we're trying to go. And when you look at all the off-label use of hyperbaric, it's just not severe and acute. It's not life or limb. It's quality of life. It's degenerative in nature. It's breaking down people's quality of life for decades and decades. And a lot of these people find symptomatic relief from lower, less intense types of hyperbaric. And so applying hyperbaric universally, let's say 2 atmospheres on 100% oxygen, whether on label or off label, is also something that I would totally disagree with. Sorry, did we lose my slides?
We did, Doctor. But so I'm going to interrupt you for just a second.
As Dr. Tattleback said earlier, we use off-label all the time. Seizure medications, pain medications, 45 to 80% off-label. Oncology medications, easily somewhere around half could be considered off-label use.
Dr. Saunders.
Other ambulatory considerations, 20 to 40% off-label. So we do this all the time. It just has to be done appropriately. And how do we do that? That's really what I want to talk about, because that's, I think, the crux of the question is, how do we make sure that if we're using it off-label, we're not just sticking people in chambers without a mechanism, a decision-making matrix to go through to make sure, again, is it safe and is this potentially going to be effective? And so when we do this, we break the mechanisms of action into 4 categories. One is mechanical. So it's helping with swelling and edema, and it's going to cause vasoconstriction. It's going to shrink gas bubbles, which is primarily not clinical, but dive medicine when people are scuba diving. But then the other 3 categories have a lot to do with why we use hyperbaric in the acute and severe, and why we use hyperbaric in the chronic and quality of life category of conditions, because there's an immune system component to it, reducing inflammation and building the immune system's capacity to fight infection. There's a metabolic component, improving the body's ability to produce energy so that they can perform the jobs that each cell needs to do, but also improve hyperoxygenation to something that's either ischemic or hypoxic due to injury, trauma, post-stroke, post-surgical, making sure that we're driving perfusion and oxygen to tissues that are essentially starving. And then there's a whole regenerative category where we're getting growth factors released, stem cells mobilized, collagen synthesis, soft tissue, skin, hair, nails. A lot of our tissues repair because these regenerative pathways are stimulated through the use of hyperbaric.
It's not responding.
If we compared that to on-label use, we can say, here's a bunch of on-label indications, and here are some of the reasons that hyperbaric works in these cases. So, decompression sickness, which is essentially the bends. Well, that mechanical component of shrinking bubbles, that's how hyperbaric works. What about all the infections that we use hyperbaric for, even in the hospital? Gangrene, osteomyelitis, brain abscesses, necrotizing fasciitis. Well, because of the ability to control inflammation, up these anaerobic bacteria that don't like high levels of oxygen, we can have an impact on those types of conditions. What about post-stroke or or crush injuries. That's where we're getting into these arterial insufficiency issues, central retinal arterial insufficiency. We're driving oxygen to these starving tissues.
Doctor. Stop him.
Only choice is to hyperoxygenate.
Dr.
And
Saunders.
that's really where this one comes into play. And then
Okay. I muted him. Yeah.
it was approved for
Doctor.
high altitude pulmonary edema, high altitude
Dr.
cerebral
Saunders.
edema. We know that we can control edema with hyperbarics. But outside of the 4 or 5 on-label.
Okay, so we have to, by rules, when we cannot be meeting in committee when session is going on, so we have to take a recess. We are going to come back in about 15 minutes. There's not a lot. Session just has to read in a few things from the Senate, and then we will come back and we will continue this committee. I apologize for the delays and how long this is taking, but I want to give everybody their opportunity to speak today. Thank you. Ladies and gentlemen, we'd like to get started again. If you would please take your seats. The House Oversight Subcommittee on Public Health and Food Security will come back to order. Dr. Saunders is going to show us one more slide and do a few questions, and then we are going to keep moving on. Thank you.
Can you guys hear me and see the screen?
Yes, we can, sir.
Okay, great. So I apologize I didn't hear you guys trying to break. My apologies. I thought we were breaking a couple minutes after that. But essentially, just wanted to end on safety. You know, there are literally millions of sessions going on every day in the United States alone. Comparing the safety record of hyperbaric to that of many other either healthcare related or other injuries or deaths throughout the course of a year, it ranges from tens of thousands to hundreds of thousands of deaths annually. And again, this is not to minimize what happened in Michigan at all. I take every accident in hyperbarics incredibly serious, and we spend a lot of time trying to understand and learn from these mistakes so that they cannot happen in the future. But hyperbaric is associated with about 2 deaths in the last 10 plus, it's almost 20 years actually. Versus all these other numbers are really deaths per year in the US. And so hyperbaric soft chamber, hyperbaric hard chamber, hyperbaric air only, hyperbaric with oxygen. Hyperbaric has an incredibly strong safety record throughout all of its different uses, both in dive medicine and in clinical medicine, on label and off label, and has so for over 100 years. The issues that we have are that people don't necessarily know which equipment to buy. They don't know which oxygen, again, not to vilify the industry, just to understand how do we help people practicing hyperbarics make sure that they're doing it right. There's 2 conversations. What equipment do you operate, and what is the facility like? And in the equipment, there's a chamber conversation, and then there's an oxygen conversation. There's a lot of unapproved devices, and that needs to be addressed. That would be the number one thing to keep people safe, would be to address the unapproved devices from being used all over this country currently. And then from a facility standpoint, what's the right policies and procedures? What are the safety procedures? What are your safety binders looking like? Do you have the right personnel in terms of safety coordinator, safety director, technician training, all of those things? And essentially, we can get to a place where we're delivering that consistently, and as consistently as Dr. Tettelbach mentioned that the hospital was doing so. And we've been doing that. For years we've been teaching this and helping practitioners do this the right way, even off-label or on-label, even in a standalone clinic, whether they're using soft chambers or hard chambers. This is very doable. We've got a pretty good track record of doing it. And so anything I can do to help Michigan figure out a pathway to getting this done for the state, which, as Dr. Tettelbach said earlier, is cutting edge because it may be something that the rest of the country follow. I'd be honored, willing, and able to also help put those pieces together. I will pause there and happy to either open it to questions or move to the next speaker, whatever you guys need.
Thank you, Dr. Saunders. We're going to start with a question from Representative McDonald.
Thank you, Chair. Okay, I'm coming in here at a time when I think this is all very complicated stuff. I hope everybody's still listening. It's a shame that we had such a long break because I really wanted to address the thing you were talking about right before we broke. And that was, you were saying that the argument is about on-label treatment versus off-label treatment. And that's not really the argument because let me just say that hard-sided units have 15 FDA-approved treatments, 15 conditions that the FDA says these work on, and almost virtually all of the research for PTSD and other issues that are related to veterans' treatments have been done with hard-sided units. The difference is soft-sided units by the FDA have only been approved for one condition, which is, I wasn't expecting to have to talk about this, but which is, as the doctor said, which is, I'll just finish my question, sir. That if somebody is up in a mountain and you can't bring a hard-sided chamber, you bring up a soft-sided chamber, you protect them, and you deliver them to a hard-sided chamber. That is what the FDA has approved. So I know that hard-sided chambers have dozens and dozens of uses that are off-label, and I'm fine with that. Nothing in my bills has anything to do with that. The concern is the amount of oxygen, whether it's 24% versus 100%, and the pressure, and that all of the research that is done, the real medical research in peer review articles, is about hard-sided chambers, and that does not automatically mean that soft-sided chambers are just as good. It just doesn't.
Is that a question, or can I respond to that, or?
Please respond.
What I would say is it's also equally misleading to say this is a hard or soft chamber situation. The material that the chambers are made out of is irrelevant to whether they work or don't work. So it's really a question of what pressures are appropriate to use for which applications, for which indications. And so to your point, hard chambers have been used in most, not all, but most of the research, and there's a lot of reasons for that we don't with anyone willing to give me the time. However, some of that research has been done at 1.3, 1.4, 1.5. And so at these more mild pressures, hard chamber or soft chamber, the material doesn't make the thing effective or ineffective. The material just makes it either easier or more difficult to get access to, maybe. It weighs a different amount, but pressure is pressure. And so, if we can decide that, let's say some of that research done at 1.3, 1.4, 1.5, hard chamber, great, but that doesn't make the material of the soft chamber. If that soft chamber goes to 1.3 and the hard chamber goes to 1.3, 1.3 is 1.3 or 1.5 is 1.5. That's irrelevant. And about the acute mountain sickness, yes, that's the only indication approved for a soft chamber. But like with a lot of other medications, there's only one approved indication. Like every approved hyperbaric indication was once off-label, except for decompression.
I'm not arguing off-label.
So, every chamber, even hard chambers, were initially only granted one indication. And over time, they gained additional indications. And the same is for any chamber or any medication or any drug available. And that's where it begins and that's how it builds. But that doesn't speak, I don't think, or not, this is an appropriate therapy for TBI, for concussion, for veterans, or anything else.
I have to respond before I get cut off here. When you say the material doesn't matter, hard-sided chambers can deliver 100% concentrated oxygen. Can soft-sided chambers deliver 100% oxygen?
Absolutely not. And the fact that where that question is coming from is implying that the 100% oxygen is what's necessary to get the impact. And also, studies have shown that that's not necessarily the case. And what we're trying to achieve. In other words, there's a great increased stem cells 3 to 4 times, and at 2 atmospheres on 100% oxygen, it increased 8 times. So both are improving stem cell mobilization at different rates, which would apply to different people with different health concerns or health goals. And there's a number of examples similar to that. But there are plenty of places that use air-only hyperbarics as their tool, knowing that they're avoiding the 100% oxygen altogether from an effectiveness standpoint. And those studies exist as well.
Doctor, this has probably been answered at one of the previous presentations. How long has hyperbaric been in existence?
I mean, the first chamber was in the 1600s, but actively in the United States, I'd say around 100 years, 90 to 100 years.
And so for most of that, just because of the way things were constructed, most of that time frame would have been a hard-sided unit. Is that accurate? About like how long have soft-sided units that have been FDA approved been available?
About 30 years, almost 30 years.
Almost 30 years. Okay. Thank you. Any other questions from the committee? Doctor, thank you very much for your time. We appreciate it today. Thanks for your patience with the break.
No, of course. I apologize for that again, and happy to help any other way that I can if the committee sees it appropriate.
Thank you, sir. Next, we're going to hear in-person testimony from Shannon Kienitz, Executive Director of the International Hyperbarics Association. Shannon, thank you for making the trip from Wisconsin to be with us.
Can you hear me now? All right. Thanks for having me. So sitting back there all morning or afternoon and listening, I think that I've changed what I've wanted to say about 5 times. I am the executive director of the International Hyperbaric Association. We are a nonprofit organization that promotes the use of hyperbaric therapy. We do encompass all hyperbaric therapy from multiplace to monoplace to soft chambers. But you've heard all of that stuff in the last presentations, and what I'm here most for today is that I'm a mom of 2 little girls, and my youngest daughter's life was saved by hyperbaric therapy. And I personally see a little bit of a danger and some stuff happening in Michigan that would limit access to families like me. And I left my family, I left my kids at home in Wisconsin to be here because I felt it was that important to be here to tell you the real side of hyperbarics, to put a face to hyperbaric therapy. My daughter was 3 years old, spent the first 3 years of her life in the hospital before they even got a diagnosis for my daughter. She has a very rare mitochondrial disease. She's one of 5 children in the world with her disease, and the only child that has lived past the age of 2. I heard about hyperbaric therapy through parent groups because the state of Wisconsin basically told us once we got her diagnosis, there was nothing more that they could do for Grace, that I should take her home and I should make her comfortable. And that's all great and everything, except for I'm also a mom to her sister Lily. And I needed to do everything that I heard about so that I knew that I could be a really good mom to my other daughter when Gracie would pass away, because according to mainstream medicine, she was gonna pass away. We started our hyperbaric therapy. I had to leave my state. I had to go from Wisconsin all the way to Florida to find one doctor that would be willing to treat her because it was, a rare disease and nobody had been treated for this particular thing. Got situated at Joe DiMaggio Children's Hospital, had a SPECT scan. of the brain. They told me the same thing. Why are you here? I'm like, I want to try hyperbarics. He told me it wasn't going to work. I said, well, I did a lot of fundraising. I can't return like the Boy Scouts and the Girl Scouts money. Like, I don't know who to return it to. So I'm going to try it. And thank goodness I tried it, because prior to hyperbaric therapy, on a good day, my daughter was 3 years old and she weighed 15 pounds. She had a feeding tube. She was blind. On a good day, she had anywhere between 100 to 500 seizures an hour. She had infantile spasms to the brain. She was on 42 pharmaceutical medications. And I get that why science told me that I needed to take my daughter home. But as a mom, I couldn't just do that knowing that there was something else out there that could help Grace. So we started hyperbaric therapy. We had gone from Madison, Wisconsin to University to St. Mary's, Mayo Clinic, New York Presbyterian, and everybody told us the same thing. She would be blind, she'd never see, she'd never understand. And I want to be honest, I'm a psychologist by trade. My brother was a physician in the Air Force. He told me it wasn't going to help. But all I wanted is I wanted Grace to know that I loved her, and I wanted her to know that she had a family that did everything they could do to save her life. And that's what hyperbaric therapy did. And sitting back there and listening to things about 1.3 versus 1.4, 1.5, if you were to pass something in this state that stated that it has to be above 1.4, I wouldn't have Grace. My daughter wouldn't be here today. I wouldn't be doing what I'm doing. I wouldn't have been able to help thousands of people. It's because 1.3 works. I went to a clinic with Grace in Florida. I was in a steel chamber, but I was still at 1.3 pressure because of her seizures, because of the things she had going on. So I think that we're getting into a situation where we don't want to get into where we're going to limit the access that we have. And then you bring the veterans into it. We know the accessibility rates of your situation in Michigan, how many clinics are out there, how many freestanding clinics are even out there doing off-label with hard-sided chambers. It's not okay to limit access, but more importantly, it's not okay to take away hope. Who are we to sit here and to say that something helps one person and doesn't help another? I didn't know I was going to get everything I got from Grace. After doing hyperbarics, my daughter got her vision back. She eventually removed her feeding tube. She eventually was able to go to kindergarten. At first grade, she walked out of her wheelchair. I was speaking at a conference in a parent group in California, because I would go around the country talking about hope and just not giving up when you had severe medical issues. And I was coming down the escalator in our local hospital, and I saw a bunch of people that I knew, and my brother was in the military at that time, and I knew that there were things going on, and I thought maybe something happened. But what happened instead was that everybody broke away, and my daughter got out of her beautiful pink wheelchair, and she walked to me for the very first time in her life. And I remember when one of the reporters asked me how I was feeling, and I asked him to just give me 5 seconds. And I said, because the only time I ever imagined Grace walking was when she was an angel in heaven. So this became very personal to me. It was in that moment in my life that said, I'm going to make sure that this is accessible to all families, to all people, to all walks of life, and started advocating for it. Like I said, I went to a clinic to start my treatment. I believe strongly in safety. I think that's really important. I think that we have more in common than we actually think that we have in common. I want to stop the illegal soft chambers from coming into the marketplace. I want to make clinics be safe. We do that at our organization. So do 6 other organizations. We don't want to limit it to any one organization. We want to limit it that everybody can have the training where they need to go to fit into their needs. But what I don't want to see is, I don't want you guys to take away hope from families like me, and limiting it would. And so it was very difficult to sit back there and listen to have it be this thing about pressure, because all I was thinking in my head is that if Grace wasn't able to get hyperbarics because she had to do 1.4, I would have missed her prom. She never would have gone to prom. She would have never walked across her graduation stage. She attends the University of Wisconsin right now in an adaptive program, so she still has special needs, but so does my typical daughter, who's 27 years old as well. So I think that it's just really important that when you're looking at everything, that you take into account that there's real people behind everything that you guys are doing right now. There's thousands and thousands of families like mine that have been helped by soft chambers, that have been helped by steel chambers, and that we need to be able to allow laws to pass that don't limit that, and that give the access to the people that need it.
thank you for taking the time to drive here from Wisconsin. It's a time of year that's not always the easiest thing to do, so we appreciate the effort. What does your association provide do you provide training? Is it accreditation? Can you explain a little bit more about that?
So we are a nonprofit organization. We're membership based. So in order to even be a member, you're vetted. So you can't be using equipment that isn't FDA approved. So if you're a steel chamber, you'd have to have FDA 510K. You'd have to have ASME PVH01. If you're a soft chamber, you'd have to have the 510K clearance to even be a member. And then from there, we do training. So all our clinics have to have a safety director. The safety director, needs to be, somebody that's trained through an accredited association. Sometimes they will go to other organizations. We partner with the International Board of with IBOM, International Board of Undersea Medicine. They do a lot of our certifications and our trainings. We also promote a 40-hour course for technicians and for functional medicine practitioners. We believe that you need to have a medical director at your clinics. Like we're not the police, but we do put things in place because it's already somewhat regulated by, even getting chambers through. You have to go through the proper channels, like through the FDA and ASME, even to get it onto the marketplace, right? But we're there to make sure that our clinics are safe, that they're doing it, and we also are there to make sure that they're not gouging. This is, I paid $200 a treatment for Grace. My family took mortgages out on their homes to have it. The newer industry, the research wasn't necessarily out there when I first started on the soft chambers. Now it is out there. So you have to look at the financial standpoint of things too. People can go to a hard-sided clinic, maybe do a round of sessions for $4,000 to $8,000, but when they can have one in their home, it changes things, right? We do a lot of parent training if they do end up doing things like that. But we really push, safety directors in clinics, medical directors. When they belong to our organization, we actually give them all the forms that they would need legally to make sure they're doing things right. We never like misleading. You don't ever use the word cure. This is an adjunct therapy that helps with other things that people are doing with their loved ones that have some type of medical impairment.
Representative Green.
Thank you so much. You pretty much answered my question through what you said, but I just, as a mom with a son with a genetic condition who's driven to San Francisco and Georgia and Colorado and Ohio for treatment, you will do anything to help your kid. They're your babies, you're your families, and even for myself with some chronic medical conditions myself. And so I thank you for your testimony and thank you for that, what you shared, because everybody deserves and should have the right to try anything for healing. And I thank you for your association who does put up guardrails, and that there are safety standards that can be followed, and people can still be treated with proper safety standards in place, but barriers from access is removed. So thank you for that.
Thank you.
I have a question. Maybe you can answer this, and maybe I should have asked someone else. I'm not sure. So I know there's been a lot of discussion between, off-label, on-label, or what research shows works at 1% of oxygen, or, at 100% oxygen, or at less oxygen. There are procedures that are covered medically through Medicare billing codes. Mm-hmm. And most of, when we talk about on-label uses for things, that's what's covered under Medicare billing codes. That's how my business operates. Mm-hmm. But then there's a whole realm of medicine that takes place outside of Medicare billing codes. And so I guess some of what we're trying to discuss, we're talking about making sure that it's safe, whether it's inside or outside of those billing codes. And so I guess just from your perspective, is that what you're trying to accomplish? It's the safety aspect. We don't care about how it's being paid for. Mm-hmm. It's more about that if it's going to be provided to someone, that it's done in a safe manner.
Absolutely. I mean, safety always has to come first when you put any individual in any type of therapy. So safety is very, very important to us and to the industry as a whole. I mean, that is one thing that the larger organizations, where in our community itself, I wish that everyone just truly understood that we really have more in common than we don't have in common. because safety should always come first. So we believe in safety. We believe that it needs to come first. We do know that hospital-based chambers are obviously a lot different than freestanding, centers, right? That's because of the cost. They're using multi-place. They're using different, forms of delivery of oxygen, which then causes a higher risk. So, that's the problem, that everything can't be treated the same way. It's not like cookie cutter, because each chamber is different. So I think that's where the industry in itself has lacked, and our organization has worked very hard to try to bridge that, to show that, hyperbaric medicine is a medicine, and it's a therapy that can help people, but it needs to be done in a safe way. That's why we have safety directors at our clinics, and we encourage that. When we find out, people are using equipment that isn't FDA, approved or isn't regulated by the type of chamber they have, they no longer can be a member of the IHA. I'm not sure if other organizations do that or not, but we really highly do that within our own group.
Thank you. Representative McDonald?
Thank you, Chair. I agree. We agree on far more than we disagree on. One of the things, one thing I just want to say this is an oversight committee, and I didn't know today that we were coming into, this is basically a policy discussion, which I wasn't told that's what we're going to be
That's
doing.
not what we're doing here.
Oh,
We're
okay.
talking about
Okay.
regulations and
I
whether
just
we
wasn't
need-
prepared. I'm just saying, I did not know this. But one of the things is, since I guess we're talking about my bill package, is that it does not stop home use. That's not part of it. So it would not do what you said it would do. I also, as I've said a few times, I'm not against off-label use. I also support the bill and creating a pilot program for veterans. I support virtually everything that you do. But I know there's one thing about accreditation. We have accrediting bodies. There are, I think you just said 5, 7 of them. Is IHA an accrediting body?
We partner with IBOM, and they're our accrediting agency. So we partner with IBOM. So
What is IBOM? Could you-
International Board of Undersea Medicine.
Okay, okay.
So yes,
So-
they are.
Okay. So anyway, I totally agree. And sorry, I could have been better prepared if I'd known that this is the conversation we were going to have today. Thank you.
Well, just if I could speak to that, the only reason why I brought up certain things was because, Representative, you're the one earlier that brought up the bills. So, I just really am wanting to get across that, especially since there was so much discussion brought up about the pressures, that it was really important to bring a human side to this, right? Because again, sitting in that back row, if you were to be 1.4, if you're going to listen to the very first 2 presenters, I wouldn't be here today because I wouldn't have my daughter. She would no longer be with me, and I know that for a fact.
Any other questions from the committee? Shannon, thank you very much for your time and your testimony. We appreciate it. Next up, testifying on Zoom, we have Carrie Reichbach, Board President and founder of the Gray Team.
Hi, thanks for having me. Can you hear me?
Yes, sir.
I've listened to everything since the beginning, and I have to agree that we have more things in common than what we disagree on. I am not a doctor. I'm a U.S. Army veteran who suffered multiple traumatic brain injuries. And I can tell you that going through somewhere around 120 hours in a hard chamber had an amazing positive effect on my neurocognitive scores. But when the funding runs out for that, we are able to continue to provide hyperbaric to the veterans under my care as I run the Gray Team. I'm the leader of an organization that has put over 1,200 service members through for suicide prevention, and we have never lost one veteran to suicide. So I can tell you firsthand that not only has it helped me, but it has helped numerous service members with all of the other therapies that we offer. It tends to magnify what is working. Now, we do use a soft chamber. And again, I believe the argument, it should not be 1.3, 1.4 atmospheres. It doesn't matter. I can tell you firsthand that from my experience and the experience of hundreds of other service members that we have pushed through, at 1.3 atmospheres with just ambient air, so there's no risk of explosion, there's no risk of a fire. We have had tremendous results. I'm more than happy to share certain testimonial videos if you guys have the time to watch them. I'm happy to share a screen, but basically that's really what I wanted to say, that it doesn't make any sense to ever get rid of soft chambers. I totally agree they should be regulated. I think that in terms of they need to have a safety factor, I think they need to be approved for all safety factors. I think that there needs to be an educational system in place for the operators. 100%. We are taught do no harm, and that has to be the number one factor. But I am able to offer something to service members who cannot get it. They can't afford it at all, and the VA does not offer it. And I know that in Michigan, you have a suicide problem with your military. I don't know the exact numbers, but I know it's quite large. And I think that, the last thing you want to do is in these rural areas is count out soft chamber usage. If it's below 1.4 atmospheres, it's meaningless. The important thing is that they are able to grab this amazing therapy and utilize it at a much lower cost. I'm happy to answer any questions that you might have.
Gary, thank you for your time and thank you for what you're doing. I want to reiterate, so we're not discussing a specific policy here. This is for oversight purposes. The reasoning is we don't have a lot of oversight in Michigan, and we're talking about how to make sure that we have access. The access is the important piece, but that access is granted in a safe manner. So can you talk a little bit about what you do to ensure that the procedures you're providing are done so in a safe and secure manner?
Absolutely. So first off, we do require that any of our service members get cleared for hyperbaric from their physician, and that is carved in stone. Nobody is allowed near a hyperbaric chamber without getting that clearance prior to. And secondly, all of our staff are trained. They have gone through extensive training on hyperbaric medicine. They know how to use our equipment. We do have an overseer that is always on premises. And on top of that, in terms of safety factors, we have somebody keeping an eye on them constantly. So really, we have never had an issue. We have been in this facility for 6 years, and not one instance of anything whatsoever, not even an instance of somebody having claustrophobia. So the soft chamber is fantastic. And I have to add, that one of the things that Gray Team does is provide care for those that can't even get to our facility. So the beauty of a soft chamber is that it is capable of being transported. And I know that you probably have the same issues in Michigan, but a lot of our National Guardsmen and Army reservists are at remote bases during their training and cannot necessarily get to our facility in South Florida. And we're able to take the treatment to them as long as they have clearance. So the transportability and making that available And we are a nonprofit, so we don't charge anything whatsoever for our services. So there is no financial motivation behind this. It's just the ability to heal. And I can't stress that enough.
Thank you again, Carrie. Really appreciate your time. Our final testifier today, joining us virtually, is Kevin Hensley with Grunt Style Foundation. No, is he in person? I'm in person. I apologize, sir. If you'll please make your way up to the stand, and then you just push the red button when you're ready to speak. Kevin serves as the co-chair of HBOT Task Force and leads the HBOT Committee for the Michigan Commanders Group. Kevin, thank you for being here.
There we go. Okay. Thank you, Mr. Chairman, for allowing me to be here. Committee members, my family behind me, the veterans of not only the American Legion, MOA, Military Officers Association, VFW, and all counterparts of what makes up over 441,000 veterans in the state of Michigan currently, and the 13th largest veteran population in the state, which is the state of Michigan. It's an honor to be here today. I will tell you that if I could, for a point of order, I would like to read something that the senator had said in his previous testimony about the bills or the enactment of bills. Currently, there are 13 states that have passed legislation for hyperbaric oxygen treatment for veterans with TBI and or PTS. I don't call it PTSD because it's not a disorder. It's trauma from a certain event or several events that happen over a period of time. They weren't born with this particular thing, and if they were, then I can understand calling it PTSD. However, a lot of veterans have it from their military service and combat operations overseas. The Senate Enrolled Act 96, House Bill 1306, Indiana Veteran Recovery Pilot Study, enacted and effective July 1st, 2017, and otherwise or further revised 2019 to 2020. Over $1 million funded through the general fund for a 5-year state-funded program, which is extended several times for approximately 32,000 of 380,000 veterans in the state of Indiana are women, and 572 are homeless. There is an estimated 18,200 TBI and PTS veterans in the state, 153 suicides per year, and 1,428 with opioid use disorder. The House passed 92-0. The Senate voted 45-0, unanimous votes. The reason why I wanted to say that is to make sure we capture the correct information that we have all talked about and discussed here today. I'm not against safety. Matter of fact, I was in law enforcement for 20 years in the Air Force. I enforced standards. I enforced rules, laws, and regulations. Also, I have a degree in occupational safety and health, so I get the importance of safety. Education and information is key to any part of this. Throughout my time as a veteran, I served 20 years in the United States Air Force. I went over and did 8 tours in the Middle East in combat operations, including Operation Southern Watch, Iraqi Freedom, Enduring Freedom, Operation New Dawn. I've seen what happens in combat, and it is not pretty. I was at the military hospital in Balad, where I was conducting a resource protection operation, and I wound up holding a plate while a doctor was taking shrapnel out of an individual who just made it to the hospital from an explosion from an IED. So I get the severity of all we're doing here and why hyperbarics is so crucial to our movement forward. It's an alternative therapy. A lot of people have problems with hearing the word alternative therapy with cannabis or with psychedelics or red light lens therapy, TMS, and then the list goes on and on and on. There is so much evidence-based material out there for peer-read review articles for hyperbaric oxygen treatment for veterans with TBI and PTSD. You want to know where it is? Look it up in YouTube and basically you can type in the search engine HBOT for veterans, and you'll find testimonials from ranks from colonel all the way down to your junior enlisted folks, your senior enlisted who got their wives back, who got their families back because they didn't know that they had a TBI or they didn't know that they had undue trauma. Hyperbarics has been able to approve for suicidal ideations. It's been able to help the homelessness, the divorce rate, the opioid dependency issue, and the reason why I say the divorce rate, because if you have somebody who has significant or severe PTS, they don't want to be around their family because they're afraid they're going to hurt them. Those are the people that we institutionalize because society does not want to see those people. But we want to treat and heal those veterans. I had the opportunity of driving over 2,200 miles to Tucson, Arizona to do 80 hyperbaric sessions, what they call dives. Yes, we did not dive underground or underwater, but at 1.5 atmospheric pressure is what I went into for 80 dives. Roughly almost 2 months I was in Tucson, Arizona. I made that my full-time job and my full-time mission for healing. I've never tried anything in my life. I was diagnosed with constrictive bronchiolitis in 2017 after a lung biopsy showed soot and ash on the exterior of my lungs, and the lung biopsy proved constrictive bronchiolitis, which is a terminal lung disease that I have. After that, I figured, well, if I've inhaled it in my lungs, where else is it gone? And definitely it went into my brain. I had a toxic brain injury where 90% of my 90% of my oxygen was deprived. Not only having that, but also a TBI, PTSD, anxiety, and depression. I was able to get that treatment by spending over $30,000 driving out to Colorado for a SPECT scan for the opportunity to get answers and provide hope and provide unity for my brothers and sisters in arms. There comes a point in time where 22 a day needs to stop. And it's not a federal issue. I don't want any more dead friends. I don't want any more brothers and sisters to die because they didn't get a treatment that was available to them to help chart their life or change their life or extend their life or their quality of life. I went to my doctor, and he's in Waterford, Dr. Sapansky at Walton Medical, and he basically told me in 2020, I had you on the shelf. I had you not living much past this. What did you do? What changed? In 2021, I went to hyperbarics. That's the only therapy that I've ever changed. I could not read a page on a book and tell you what that page said. I was reading 300 to 400 page books and giving you cliff notes of what those books said. The change was astronomical. I got an opportunity to go in a multiplex chamber where I saw veterans who had weapons in their mouth 2 or 3 days before they went to treatment. Same body, different inside. They could not fathom that they would even try to harm themselves. I have responded to 58 suicides, attempted, stopped, or completed in my years in law enforcement. I've seen domestic violence situations, and I've seen not only in garrison what people can do, but I've also seen in combat what people can do. And something needs to change. Pills don't work. I was given a blood pressure medication off-label for my PTSD. I've never had high blood pressure in my life. So if we're allowed to off-label blood pressure medication for a PTSD treatment that's not actually for PTSD, then why not? Why not HBOT? Why not try it? Because what's going on in suicide prevention is not working. If we were moving the needle back, then I would say yes, these things in these programs are working, but they're not. 22 a day. Some will argue that it's 38 or 44. Some will argue that it's 17. One time they had it for 17 and they took their Guard and Reserve out. Last time I checked, when did the Michigan Guard deploy? Pretty recently, right? Could you imagine coming back home? I think they went to by Jordan and Syria, and there was a huge explosion there. Luckily, none of our members that I know of were injured in that. But could you imagine if they were injured and they came back home and they got treated with hyperbaric? 20 sessions, 30 sessions, 40 sessions, and they were put back to full service instead of kicked out of the military because there was something wrong with them? Imagine that. Israel uses hyperbaric for their soldiers when they go to war. They put them in the hyperbaric chamber because they don't have the luxury of making more. They want to keep their soldiers fit, they want to keep their soldiers healthy, and they want to keep their soldiers back into the game and back into the system of the military. It's a great idea, especially when we were facing challenges at one time in the military of roughly 60% of our military force. 40 or 25% of them may be able to fill out the military due to ADHD, autism, obesity, whatever other kind of serious medical issues that they had previously, or they just weren't a good candidate for whatever reason. This is the way this is, excuse me, this is what is happening to our nation. And let me tell you, alternative therapies, I didn't know much about them. I will tell you that. But let me tell you, when I got the opportunity to go to Arizona and they told me I wouldn't have to have surgery, wouldn't have to take any more pills, I was on so many medications that it was a full-time job. I was over 48 medications. I couldn't even screenshot it on my phone. I had to take 2 screenshots just to get the medications on there that I was popping pills every single day. It was like a full-time job. And then with my cognitive function issues, I couldn't even remember if I took one or not. Even though it said the Sunday through Sunday thing in the pills, I couldn't even remember if I took them or not. I had to look inside just to make sure I took them. So what I'm asking this body, and I know we are talking about policies and safety and stuff like that, I was in a safe environment. Took my shoes off, so I was grounded. Took the key fobs out of my pocket, took the cell phones out of there, took any kind of static, electric, magnetic things out away from it. I didn't change my clothes like some places make you do. They make you go into your garb or your medical, what do you call it? I don't even know what you call those things, but your medical, your medical garb. And I was able to heal. Now, am I better? I got an oxygen, right? But if I took this oxygen off, you would not know any different because they're invisible wounds. We have the opportunity now to see those invisible wounds. I can show you pictures of my lungs. I can show you pictures of my brain scans. We can see those medical those medical phenomenons that are happening in technology every single year. The situation that's happening, though, is that we are at a point to where a young boy named Thomas Cooper passed away from an accident that happened in Troy, Michigan. Why is that so prevalent to me? It's because my grandson went in those same chambers in Brighton, Michigan. And I am not going to testify on what's happening right now because that's neither here nor there. But as long as we are practicing safe policies, safe procedures, we are not limiting rural areas and people from access to treatment, then I'm all for safety standards and the choices of safety standards, whether it's 1.3 soft chambers, a hard chamber, delivering oxygen at 24%, 40%, 100%, whatever the case may be. I'm a proponent of healing because I'm not supposed to be here. I thank you all for the opportunity to stand in front of you or sit in front of you today and give my testimony. And as this, I'll answer any questions that you may have.
Mr. Hensley, thank you for being here and thank you for your service. I don't see any questions. I don't think there's probably going to be any questions. I just want to say, so the purpose of the committee the last couple of weeks, or I guess we had a little bit of a break between the first one and this one, is to establish that hyperbarics are going to happen in the state of Michigan. It's happening now. There's medical necessity. We see that. The question before us was, should the state be regulating that in a different way than they currently are? I believe the only current regulation is through Joint Commission and a hospital-based system. I know that there's competing, I won't even say competing. I know there's policy ideas out there, a couple different ones, that are going to have their day in front of a policy committee, not this oversight committee. I think what we've established is that we should be doing this in whatever way that it's going to be conducted through safety standards and with oversight. through accrediting agencies, whether some of that comes from the state or the state requires certain accreditations. But what we want to ensure is that people have access, people get treatment, and that it's done so in a safe manner. So I really want to thank everyone for the time that they took to be here today, to testify, to tell your stories, and we look forward to working with all of you as these policy discussions happen moving forward. So I want to thank you again, and I really appreciate everyone's time.
Thank you, Mr. Chairman. Thank you, committee.
With that, the Oversight Subcommittee is, with no further business before the committee will stand adjourned.